Good afternoon, ladies and gentlemen. Thank you very much for joining this session of which is called TAVR Implantation Techniques. Are they the same for self-expanding platforms? My name is Gintas Bilauskas. I'm an interventional cardiologist and I practice in Copenhagen University Hospital, Denmark. I'm surrounded here by, I happen to be an anchor person for this session, and I'm surrounded by a esteemed panel here of 7 colleagues. Maybe a quick round of introduction, like just a couple of words to state as your name.
Yeah, my name is Giuseppe Tarantini. I'm an interventional cardiology at University of Padua, Italy.
Alfonso Ielasi, interventional cardiologist at Galeazzi Hospital, Milan, Italy.
Harish Mehta, interventional cardiologist, SL Raja Fortis Hospital, Mumbai.
I'm Javed Iqbal, and I'm a cardiologist at Sheffield in UK.
My name is Anmol Sonawane. I'm an interventional cardiologist and structural heart specialist in India, Mumbai.
I'm Ignacio Cruz, interventional cardiologist from Salamanca, Spain.
I'm Bhupati, professor of cardiology from Chennai, India.
Okay, so strong Italian, Indian, UK presence. Yeah, like that's what we have on the stage. And what we will try to do here, we will try to look into implantation techniques of tall frame self-expanding TAVI devices. So this is applicable to most of them, but for case examples we will use Hydra valve as it is an SMT sponsored session. We will show a few case examples from Copenhagen, and my colleagues will show a few case examples from elsewhere, I guess. Yeah, so
yeah, that's brilliant. I think without any delay we would ask Gintas to actually come here, and they have been doing using Hydra for a long time in Denmark. They have got vast experience of it, and he's going to show us some of case examples and some of the techniques that we can use for the self-expanding, and especially for Hydra, and how it differs from some of the other self-expanding valves. Over to you.
All right, let me see if this opens up. Okay, all right. Good. So, as said, the title of the presentation is Implantation Techniques for TAVR using tall frame self-expanding devices. I have the following conflicts to disclose. To begin with, as everyone knows here, of course, TAVI is a expanding field which is growing exponentially throughout last decade or more, 2 decades basically, in all parts of the world. The guidelines are now suggesting TAVI to be the primary choice for every patient of older age, and even the patients in younger age group under age of 65, as we probably have seen this slide multiple times before, like half of them, even in the age group of 65, they are actually in the United States, they seem to be receiving TAVI as the therapy for calcific aortic stenosis. So, of course, this expansion of the technology, it led to focus on how to improve it, as so many people receive it. And initially, when the technology emerged, we were focused on acute procedural success outcomes, but progressively, with younger patients being treated with this, we are looking at the lifetime patient management, at how to treat degenerated valve, how to avoid the pacemaker, how to ensure durability and optimal hemodynamic outcome. Now, this vast expansion and implementation of TAVI in many countries and many centers and many patients, of course, it went through an evolution of how you do it properly. When it began many years ago, most people would be using the so-called 3-cusp coplanar view to begin with, to cross the valve, to do balloon aortic valvuloplasty, to deploy valves. And we know that this 3-cusp coplanar view is usually an LAO projection. And we noticed also in many sites around the world that when you work with tall frame self-expanding devices in the LAO view, there is a small issue to observe. That's if you want to take the parallax off your tall frame self-expanding device, you have a parallax in anatomy, in native anatomy, where the cusps are no longer aligned in one line, and understanding properly the depth of the device might be problematic. Anatomy and the device have separate so-called S-curves, and on the LAO side these curves are separated more than they are on the RAO curve, on the RAO side. And this observation, it led to invention, or so to say, so-called cusp overlap view, where the right and left coronary cusps are overlapping on the right of the screen, and the non-coronary cusp is isolated on the left of the screen. And in this view, it's usually RAO caudal projection. In this view, even when we work with tall frame self-expanding devices and we take away the parallax of the device, usually anatomy is not so much tilted. The annulus is also very close to being in plane. Now, this leads to improved outcomes, as was tested, like at least in one of the studies I can share with you. It comes from our own institution, where we looked at the effect of this using patient population receiving Navitsa valve, because that was the valve we were using at that time to a bigger extent. And these were matched patients. In part of them received the valve in the classical LAO implant, another part of them using the cusp overlap technique. And what we observed was that this confirmed that in LAO view, anatomic tilt is more pronounced than in RAO implantation view when we compare those degrees of tilt using the knowledge from the CT analysis. Significant difference, and this led also in this population of patients to significant differences in the pacemaker rates, because RAO caudal view, which is cusp overlap view, leads to better understanding of the real depth of your device below the annular plane. So it seemed to be worthwhile to use the cusp overlap view during the deployment of the device. Now this was adopted by most, I would say, companies of who sell TAVI technology, TAVI devices. And another example of this is Optimized Pro clinical trial or study that was. This is regarding Medtronic Pro Plus device, and in this trial, the key message was that if you comply with these main 4 steps of the procedure, and the steps are: stay in the cusp overlap view, use stiff wire in the left ventricle, deploy the valve using only cusp overlap projection alone, make sure that it's a 3 millimeter below the pigtail in this particular view, release the valve, and if you comply with these steps, simple steps, without using any other projection, just cusp overlap, it appears to be associated for this platform with better outcomes across the board: less valve migration, less valve embolization, less reintervention, less pacemakers, as compared to other techniques where you don't comply with these recommendations. Now, so have we cracked the code? Should we just use the cusp overlap and it answers our questions every time and leads to better outcomes? So let me show you one example which, to my knowledge, or to my understanding, does not illustrate that it's not the final answer to optimal techniques. This is an example of Evolute case also, and it's deployed using this first image is a cusp overlap projection, which seems to be in a reasonably high but okay position, the valve. Then if we check it, if we just bother to go and check the same valve, how does it look like from LAO? We see that on the LAO side, it's rather deep, it's asymmetrical, it's higher on the non, it's deeper on the left, there's some paravalvular leak there. And if we reposition using proper tension techniques on the wire and the catheter, we can end up in a very similar RAO view as it was on the first image here. So very similar high position on the RAO side, but on the LAO in this case, it's much higher and much more symmetrical with the non side. With a very good final result afterwards. So this illustrates that, to my understanding, just looking at the RAO view alone, cusp overlap view, is insufficient, because you may miss important things. Maybe it will work, kind of, mostly, but not always. So my message would be the following: avoid that valve tilting and aim to the symmetrical deployment where the depth in relation to the non-coronary cusp and the cusp overlap view is more or less similar, as much as possible similar or the same as the depth on the left side in relation to the left coronary cusp, and try to centralize the delivery system in the ascending aorta. Now, it is important to understand and remember that for any given configuration of aorta. Aorta can be more vertical, can be in the middle, or very horizontal. In any of these configurations, the tall frame self-expanding devices, they can arrive in a vertical position, like closer to the inner curve. They can arrive in the central position within the ascending aorta, where more or less symmetrically deploy in relation to the non and left side. And they can arrive, the self-expanding devices can arrive on the outer curve, like in the two horizontal position, in any given configuration of aorta. And what I would recommend to aim for, what we try to aim for in Copenhagen, is central position of the valve, where the depth in relation to the non-side and the left side is as much as possible symmetrical, and the valve, the delivery catheter, sits symmetrically in the center of aorta before releasing. Because if your device is sitting too much on the outer curve or on the inner curve, what will happen after the release, it will have to tilt and to take the shape of aorta. Because it's a tall frame self-expanding device, takes the shape of aorta every time, and this will lead to the change at the bottom as well. It cannot not change. It will have to tilt and it will change, and you don't know what's going to happen. It might be that one side of the valve will go down, the other one will go up, and maybe it will land just perfect. But it could also be that one stays very high and the other one goes way too high, and you will face a risk of pop out, or the opposite. It may end up being too deep. So having it in a symmetrical way, in a symmetrical position, it allows to have a more predictable outcome when releasing the device. So how do we do it in our center? And this is only our approach. It might be different in some other centers, and we're here to discuss it. We, in fact, rarely use three-cusp coplanar view for tall frame self-expanding devices. We usually begin with cusp overlap view, the classical one, where we isolate the pigtail and the non-coronary cusp on the left of the screen. We cross the valve, we begin our procedure there, but we would always check in the other cusp overlap, so-called, left coronary cusp isolation view, which is in LAO projection overlapping the other two cusps, the right and non, on the left of the screen. And even though in this LAO view we know anatomy, the annulus will be tilted, but we still believe that this view is the best one to assess the real depth in relation to the left coronary cusp, and also the best view to assess the centrality of your catheter. Is it on the outer curve or is it on the inner curve? Because in the RAO view you don't see that. You don't see the arch of aorta opened up. So that's the reason. And how to achieve it? Properly aligned the catheter. All you can do is use wire tension techniques to aid with proper alignment. You can either push or pull on the wire, and you can do the same on delivery system. You can start neutral, or you can start high and apply some push while you're unsheathing, or you can start deep or deeper and pull back as you unsheathing to get away from the outer curve. These are the basic techniques that you use. Yet again, we aim to have a central position, symmetrical position, central position of the catheter, and we try to avoid these tilted ones. Now, are all devices the same in their behavior? How do they differ? So to my understanding, the stiffer capsule, the stiffer catheter, it tends to arrive at the annulus in a more vertical way. I believe that was true to most older generations, for example, of Medtronic valve. That was slightly stiffer system, the older generations, that would typically come vertical, and maybe that's why in this optimized trial or study, it worked just to stay in the RAO, and you kind of aim high, and usually works. But softer catheters tend to arrive more horizontal, more to the outer curve. And to my understanding, both too stiff, too vertical, and too soft, too outer curve positions could be problematic to achieve best possible outcomes. This leads us to Hydra valve, which is also one of those tall frame self-expanding devices. To my subjective understanding, this is like somewhere in between the soft and hard devices. It very often arrives right in the center, not too soft, not too hard. It's like self-expanding supraannular bovine a pericardium device. It has a 3-tentacle design in contrast to, let's say, Medtronic valve. It has a large frame cells. It has supraannular valve, hopefully for best possible hemodynamics. Radio-opaque markers are present on the frame, and interesting to observe that this was the first, to my knowledge, device on the market, featuring the dots, the markers on the frame, which is now adopted by a few other ones. And non-flared inflow, hopefully to avoid pacemakers. 3 sizes are available. And why could we like this device? I'm not saying it's the best device out there on the market. There's none which we could call the best. They all have their strong and weaker parts. So this one, among the strong ones, I could say it's fast and easy to load. It's small insertion profile. It's flexible delivery system compatible with 14 French sheath, or equivalent rather. 14 French sheath. Excellent visibility of those positioning markers that are very helpful to aid the positioning of the device or to take away the parallax. It's supraannular, so hemodynamic performance is excellent. The gradients are documented in trials to be low, single digit. Ease of access of the coronaries is not too dense mesh, so not too difficult to go through that stent frame, and low rate of conduction abnormalities again, and in at least some trials it's like single digit numbers that seem to be the case. Now with this valve we try to position it not too high. It's not a flare design, it's like a rather cylindrical design of the frame. So it's typically 5 to 6 millimeters below the annulus, and the bottom dots can be used as an excellent marker to achieve this depth. They are located 5, 6, 7 millimeter above the edge, depending on the size. Smaller size is 5 millimeters, bigger size 7. So it can be used to gauge your depth. And I repeat myself now, this ideally should be symmetrical on both sides, very important to my understanding, and that's why we check it in 2 different projections. Now, final part of this talk will be a few case examples from our own institution, which I hope will illustrate the point. So we will not go to any CT scans or anything. This is a focus on angiographic techniques of valve deployment. So this first case shows we always begin with initial positioning in RAO view. So it's a cusp overlap view. You see a pigtail in the non-coronary cusp. The other 2 cusps are overlapping. We start our unsheathing there. And then we check the result in both RAO and LAO. And here in LAO, we see the valve is rather symmetrical, central, so this would be good, but this is too high. Remember, it has to be 5, 6 millimeters below the annulus, and this one is close to 0. That's the thing that we don't like, so we go ahead and reposition. It's repositioned lower, but this time landed not too well, more on the outer curve, deeper on the non, still very high on the left. And you can only see that if you check from LAO view, actually. So we go ahead and redeploy again, and this time we start slightly lower and we pull back as we deploy gently, and this leads to more symmetrical deployment, more or less 4 or 5 millimeters, a tiny bit deeper on the non, slightly less deep on the left, slightly biased on the outer curve, but better than before. And we also double check in both views always before we release, so LAO and RAO, and they seem to be both quite acceptable. And you see how different they look. If you would only use RAO, a cusp overlap, you would miss this image, which shows you how different the valve can look like in terms of height on different cusps and in terms of centrality in aorta. So this is seen as a good position, and the valve is released, and we have a perfect final position and final result. Second case, same thing. We start RAO, always RAO, and unsheath the valve in this RAO projection, using the dots very nicely and easily for gauging the depth of the valve. We check it in RAO and in LAO, both views, and in this case they seem both to be good. We are at 4 millimeter or so, 5 millimeter maybe in depth. It's rather central, a tiny bit biased on the outer curve, but aorta is not very wide. The tilt will not be dramatic. The STJ is almost being touched by the valve there. So we go ahead and release that, and we end up with a good final result in both LAO and RAO projections. Case 3, same thing. We start in RAO. The valve is unsheathed. Sometimes we observe that the device gets into a lot of parallax as you start unsheathing. We see it sometimes. What to do? So we just continue unsheathing, but then we take away the parallax. So we move away from cusp overlap view into some caudal view with no parallax, and check in both caudal and LAO views. They both show the valve being too high position. So we go ahead and reposition the valve in RAO caudal view, trying to optimize the depth and also trying to keep the parallax away to understand the depth a bit better. And now we have, to my understanding, quite proper symmetrical depth of the device on both sides. And I believe this should probably be released. Yeah, that's what it is, and leads to a very good final result. I should probably be stopping, but let me show you maybe one last case here. I don't know. I believe we should leave some time for discussion here, but yet again, initial release goes in RAO view, and then initial parallax here as well. So this happens sometimes. So then it's important after the valve is released to initial 80% to take away the parallax and check what we have in both RAO caudal and look at that. Like here you might think this is maybe perfect. It's not too bad. Slightly highish, but nothing too crazy. It seems to be quite symmetrical, seems to be quite acceptable. But if we look on the LAO view, you see that it's completely on the outer curve and very high in relation to the left coronary. So this is not good. So we reposition, we try to make the device more central, more symmetrical. To achieve that, you would start a tiny bit deeper and you deploy the device with a gentle pullback to go away from the outer curve. And this leads then to a more symmetrical, more central catheter position, symmetrical deployment on both ends, left and right. And after release, I believe we end up having a good final result with no PVL and no conduction abnormality, so good outcome. There's a case number 5, but I think we can quickly skip through it. I think that's quite enough to show the point. In summary, what I try to convey is basic techniques and logical approach to any tall frame self-expanding device. We apply the same techniques and same logic and same geometry assessment for any tall frame self-expanding device. And there are many currently on the market. There are maybe 4 or 5, so it depends what you use in your own institutions. It's still, we follow the same logic on all of them. Thank you so much. I would be happy to take any questions.
Fantastic. That's excellent start of the session with a brilliant overview of not only the implantation of the Hydra valve, but you nicely covered the implantation of the self-expanding valves and then how to optimize any self-expanding, especially Hydra. So just bringing the focus onto the Hydra, would you like to just give a brief summary of point 1, 2, 3? How would you do it different than other self-expanding valves?
But I would not say that I do it different than other self-expanding valves. The only difference is how deep do you land the valve. That's indeed, there are differences in shape. You know, some devices are flared, like let's say Evolut platform. The Evolut, due to the flared shape, usually is positioned higher. Others are cylindrical or more cylindrical, non-flared, like Hydra or Navitor, or there are some others on the market. So these typically have to land slightly lower based on the IFU. And I think that is the only difference to me, basically. Otherwise, I aim for the for the same symmetricity with all of them. Depending on the capsule stiffness, you may face different challenges with different devices. As I showed in one of the slides, stiffer capsule would lead to the more vertical device. So if there are any colleagues working with Evolut Pro series, Pro Plus, that's usually a little stiffer. It's more likely to come vertical. And if there are anybody working with Portic or Navitor platform, is a bit soft and more often than not comes on the outer curve in a more horizontal fashion. So those challenges might be difficult, different. And ideally, you want a balanced system which comes central and not so much horizontal outer curve biased or vertical inner curve biased. That makes life much easier if it comes in the center. I think Hydra quite nails it. Not always. You saw some cases it has a tendency also to go one way or another depending on your deployment technique. But with all of these platforms, I think we employ very similar logic, and we start the same RAO caudal, we check the same LAO, we try to understand, is the device central, outer curve biased, inner curve biased. We, if necessary, reposition, applying the necessary correction in wire tension and catheter tension techniques to counterbalance the tendency of the device for a given anatomy. And the only difference is how far below the annulus do we aim to land it.
Yes, I agree. I think that's right to say that the logic behind that you nicely explained is the same, but at the same time you have also explained that yes, the depth of the implantation based on the properties of the device, we need to be careful. Any more questions from Gintas or from the audience, you can also put the question on the app if you want, or you can ask the question.
I think I think another part of the presentation was really, clear, bright. So the point I would like to add something. Actually, with this valve, but with all the tall frame valve, what is important is that when you focus on the initial positioning and you push too much towards the outer curvature of the aorta, and you have an expansion of the valve that is a little bit asymmetric, the problem is not only the rate of PVL or regurgitation, but what is recommended is to go deep and then to pull a little bit back to change the angle. And this angle is very important to change this angle, because the risk is at a long term, especially with horizontal aorta, the risk is to hit the aorta and to create some problem during the twisting of the heart, and to create, late rupture at the level of ascending aorta, things like that. And actually now, with other platform, there are new evidence that are coming up in this regard, because actually if the valve is in horizontal aorta is totally tilted down, actually there is a kind of continuous hit of the ascending aorta. This is not the way to go. So his recommendation to go deep and then to pull and to change the angle is very important, not only for the functioning of the valve, not only for the perfect alineation of the distal part in the ventricle, but also to be safer long-term follow-up for the ascending aorta. So I totally agree with you.
One thing I will repeat again is not only the depth symmetricity is the point of the presentation. Also, I would want you to remember, just apply the same method of checking in two projections for any device. Just check in two projections. It's so easy to remember and so important, because sometimes even the update of the system may lead to different behavior. We've seen that happen with so many other systems on the market. One of the more recent ones was introduction of, let's say, FX platform for Evolut, a device which changes the amount of stiffness or softness in the capsule significantly. And then if you were used to implant the device only in, for example, cusp overlap view alone, as was shown in Optimized Pro study, and you keep using it, you suddenly may be facing yourself with the pop-outs that yet you never had before. Is because you fail to realize that the other side of the valve might be sitting completely wrong if you don't check. So that's a very important step, just to check it in two projections before you do your final release, and aim for symmetricity. Like that symmetricity allows a more predictable final outcome. The problem with self-expanding tall frame devices is that some people would say that the final result after you release it from the catheter sometimes is different from the one that you had before release. Yeah, it's like the main challenge with it. And what you want to achieve is to make it predictable so that it stays exactly as you positioned it. And the key, to my understanding, is to have it symmetrical and central.
And precision is important, because actually you can reduce the pacemaker rate. Because actually if you don't go too deep, and actually you can, elongate the membranous septum in this area of view, actually you can be more precise and reliable also in terms of, let's say, the incidence of new conduction disturbances. So this is something very important to double check for all valves, but balloon expandable valve. But sometimes I used to do also double check with a balloon expandable valve if I have a significant paralysis or a significant torsion of the two axes.
To be honest, the session here is a technique of self-expanding devices, but I actually use the same principle also for balloon expandable. Whenever you position the balloon expandable catheter across the arch, it can also differ very much how much inner curve or outer curve bias that catheter is. And by applying same principles of tension techniques, you can actually have that catheter too, either more central or more away from the center. And that may lead, to my understanding, to some different...
We've got a question from the audience. Any risk of unfolding during valve retrieval?
Infolding. Yeah, of course. Excellent question. Yeah, of course, so infolding is the situation where the stent frame is pushed inside of the circumference of the valve, so to say, and it usually happens It's not that often that it happens, to be honest. I don't think I recall even a single case with a Hydra valve that I would see infolding. It's more known with some other competition systems that it may happen. Usually the predisposing factors are two, to my understanding, is very asymmetric calcification at the level of aortic valve or upper LVOT, like a chunk of calcium which is pushing against the catheter. That's one. And the second one is resheathing, because at the time of resheathing, it's more likely that this calcium will push the frame inside, and it will be, grabbed by the capsule, and also will go inside of your catheter and aggravate as a result of the resheathing.
So actually, one point, because sometimes when you unsheath the valve, not this valve, because actually I haven't seen the infolding so far, at least in my experience with this valve, but in the past I've had a couple of infolding with other prostheses. The good thing of this valve is that having the marker, when you start opening the valve, you have an infolding because of many reasons. Actually, you see that the 3 marker beads are not in line. One is above, one is below, etc. Because when you have a situation it is not clear, you have, an uneven distribution of the 3 markers, and this is the general principle to know that it's better to not going up and keep going to open up the valve. So this might be another trick to keep in mind. I don't know, Alfonso, you have any other?
Well, no. In my experience, I've never had cases of infolding with Hydra, probably because also the density of nitinol is lower as compared to other competitors. Of course, resheathing is one of the key factors contributing to infolding, but as Giuseppe told us, looking at the markers is a good point during the resheathing in order to tackle the infolding, to release infolded valves, which is a potentially life-threatening situation.
We should almost move forward, but one final thing I will say, now in the context of discussion with infolding, which I missed, I think, in my presentation, when we talk about techniques, what about pre-dilatation?
Yeah,
I would ask Anmol, can you elaborate?
No, one of the most important risk factor for infolding is bicuspid with that calcified raphe, which cause a significant amount of resistance. And when the valve doesn't open on that side, and when you resheath it, that tends to cause more infolding. It's commonly seen, I think, in India, at least in bicuspid anatomy. A good pre-dilatation is certainly have a significant role, which can avoid this problem significantly.
If I would generalize the question, how do you ever, with self-expanding devices and calcific aortic stenosis, not pre-dilate?
No, I think.
Do you accept
to pre-dilate 100% of cases?
Yeah.
100% of cases when I have a severe calcification, high gradient. Actually, I like to pre-dilate because I don't want to have the surprise to don't have the expansion of the valve and to have some, tricky situation with the delivery to take it out the delivery. So this is the reason why I never seen major problem or, major aortic insufficiency, during the pre-dilatation. I've had some bad surprise without pre-dilatation.
Exactly. I was willing to hear that comment because we also pre-dilate 100% of calcific aortic stenosis, no matter what calcium is so important thing. But I think we need to move forward. Yeah, we are getting behind the schedule. So the next talk will be Dr. Bupati. Yes, it's a case presentation. Patient with a aortic stenosis and bicuspid aortic valve. Welcome on stage.
For the opportunity. Thank you, SMT. So let's move on to the presentation. Okay. So just a glimpse about bicuspid aortic valve. We know bicuspid aortic valve is quite prevalent in India because we are also encountering TAVR procedure in younger patients. More than 80 years, it's 20%. More than 60 years, it's nearly 40%. We know the classifications. Pretty difficult to do a type 1B, self-expanding valve in a type 1B anatomy. You might have to upfront take a snap. That's one suggestion what I would suggest. In bicuspid, these are all the issues what we face. The patients are quite young. They have aortopathy. They have less non-circular annulus, asymmetric classification, raphe, high calcium scores, frequent atypical location of coronary ostia. So your commissure alignment may not work here. Measurements multiple classification, how exactly should we take the valves are available. Most of the patients studies have excluded such patients except notion 2. There's one such study that there was a global study where they studied patients with bicuspid aortic valve and TAVR registry. They found that a calcified raphe, a severe calcified raphe that is extending full length of raphe, number one, and calcification of the leaflet more than 382 millimeter cube is a high risk factor for MACE event. You can appreciate the events, 25%. So if the patient is young and if you have these two risk factors, I would suggest to go for SAVR rather than TAVR. These are all the issues that we encounter with in such patients: elliptical annulus, asymmetrical leaflets, fused commissures, and aortopathy. Different methods of selection of the size of valves, starting from conventional annulus based, Bavard based on the annulus kind of a reverse conical, or the tubular anatomy. The commissural method, ELIRA method, where we look at the perimeter, the site of the raphe, 8 millimeter above, or the Casper. Casper is a little more, it looks like a complicated one, but it gives rise to better, much more safer anatomical one. Based on the strategy, it could be utilized for either type 1, type 2, or type 0 anatomy. So let's look at this particular patient, a 71-year-old male, symptomatic severe aortic stenosis with mild to moderate aortic regurgitation, NYHA class 3 symptoms, normal LV function, non-obstructive CAD. Type 1A anatomy with a mean gradient of 45. Let's look at the annulus. Annulus is mean diameter is 22.1. The minimum and max is 20 and 23. LVOT is almost the size of the annulus. The difference between other self-expanding platform and this platform, as Gintas told, 5, 6, 7, the markers lies at 25, 22, 26, 30. The marker lies at 5, 6, 7 millimeters. So we measure the LVOT even up to 7 millimeter if your anatomy is needs a 30 millimeter valve. You can appreciate the type 1A raphe calcium. The calcium extends all the way from nearly till the commissure. So this it's one point that favors that if the patient is a higher surgical risk, we could go for TAVR. We also measure the intercommissural distance at the level of 4, 5, 6, and 8 to look at the anatomy based on Bavard strategy. The SOA was quite good. It's 34 millimeter average SOA. STJ was quite good. As actually quite a little dilated because of bicuspid aortic valve. Ascending aorta is not much dilated. This is the angle of this particular patient, coplanar angle. The cusp overlap angle, I could not get the photo. It's RAO caudal, RAO 15 and caudal 15. The LV aorta angle is not steep. If you look at this angle, it's 55 degree, 53 degree. In general, it's going to be 70 degree on table. You may have to add 15 to 20 degree. Any angle more than 45 degree is called as a steep LVAO angle. You can appreciate the calcium looking in the entire descending thoracic aorta and the aortic valve. Again, the calcification score of the right is 838. That is more than 382. It's going to be a poor prognostic factor for TAVR as per the BA international registry. The femoral axis were quite clean, more than 5.5 millimeter. More than 5 millimeter, we can take 14 French, and after every 2 French, we have to add 0.5 millimeter, the mean diameter of the vessel. Not much tortuosity. So this is the evaluation chart. This is the IFU suggested by Hydra. From 53 to 63 is 22 valve. From 63 to 74, 26 valve. From 74 to 85, 30 valve. The other larger XL valves are in picture now, and they are in the process of making intermediate valves too. There is a small difference between the numbers, the perimeter of Hydra as compared to the other platform. Keep it in mind. Don't extrapolate your knowledge of the other platforms to this platform. So ultrasound guided access was taken. This is the right main axis. Left side we have put a temporary pacemaker and pigtail. This is the aortogram in RAO caudal view. You can appreciate a densely calcified aortic valve with some good amount of aortic regurgitation. Temporary pacemaker has been placed from the neck, balloon tip pacemaker. A 14 French cook sheath was inserted. through the right groin, through which we have taken a AL1 catheter, and we are trying to cross it with 035 Teflon wire. One suggestion is we start crossing with a regular LAO angle. If you don't cross, if it's a type 1A, we go to RAO caudal to cross. If it is a type 1B, we go to LAO cranial, so that we overlap we make them bileaflet. It will be easy to cross. It was too tight we encountered some difficulty in crossing the valve, but ultimately we could negotiate this AL1 into the LV. We pre-dilated the system, pre-dilated the valve with a 20 millimeter balloon. The minimum diameter was 20.6. We generally undersize, kind of a 0.5 millimeter to 1 millimeter smaller balloon for bicuspid. I would strongly recommend to pre-dilate if you are planning to utilize Hydra valve. Once I thought, let me try without pre-dilatation, the valve did not expand well. That I learned by a hard way. We have to pre-dilate for this valve, especially if the calcium scores are little high. Rapid pacing was used to pre-dilate, and patient remained stable. And you can appreciate the it's a very good system. It's a non-braided system. The way how it crosses the aortic arch is you can appreciate. If you go to use other systems, you can appreciate the difference. It's quite simple, straightforward, single movement. Once it crosses there, we usually stops and go to RAO caudal, check our pacemaker first, and then if the angle is quite steep, before even while ballooning itself, if it is quite steep, we will change the wire up front, or even we redo everything with a snare. Usually snare is not needed for a type 1A anatomy. However, type 1B with the steep LVO angle, we may have to upfront take a snare. Then, as Gint has told, we kept the pigtail all the way down. We remember that sometimes you may not be able to get the pigtail all the way down. You have to go with the calcium markers. You can appreciate good amount of gap between the lower motion of the pigtail and the valve. We are trying to release it. We checked in. We are in the center of the arch. You can appreciate that. We usually get the blood pressure down to 70-80 systolic blood pressure once the annular contact is obtained, and go up to 80%. And stop there, reduce your pacemaker and check an angiogram and see what exactly is happening. This is quite deep. You can appreciate, especially on the left side, quite deep. So we want to recapture it. Invariably, once you start removing the unsheath the valve, slightly dives in. Now the skill of partial recapture and pulling it helps. So we try to recapture it. Once you identify the particular angle where there is no parallax, usually it is once you start deploying an RAO caudal, there will be parallax with the system. You remove 15 to 20 degree of RAO. That means if it's RAO caudal to RAO 20 caudal 20, you usually go to RAO 5 on caudal 20. You will be able to see the non and the left. That is essential to remove the parallax and look at the depth on both the sides. Okay, again it didn't work out well, so we thought, okay, we have to aggressively pace and do positioning well. So again recaptured it.
Actually, can you see during the first two attempts, the marker beads were on different plane because was not, perfectly orthogonal, etc. So actually, this is a very important marker to understand that if you're doing the right things or not. Now they are perfect.
Yeah, now they are perfect.
Can you look at this? This is one of the most important tricks that you can have.
Yeah, you can appreciate.
Look at this. This is.
The three markers, as Dr. Anthony was telling, are on the different lines. So there is a parallax and the depth is going to be different. So in the final thing, Once you are once you adjusted the wires, kept the system in the center line, you can appreciate all the three markers are the same line. Okay. So this appeared a reasonable depth on the non-side. On the left side for us, this is the second, third time we are deploying it. We accepted the depth and we released it. And you can appreciate an under expansion in this particular raphe zone. There is some amount of PVL, so we post-dilated it with a 22 millimeter. The mean diameter was 22.5. We took a 22 millimeter balloon and post-dilated it. Yeah. This is the final angiography of the particular patient.
Can you go back one slide? Yeah. Very quickly. I think it's difficult to show, but let's run the video. Let's run the video. Yeah, I know that. Just
Which
to finish.
one?
On the 10 o'clock. 10 o'clock. As you can see there, the importance of the axis there, you can hit the aorta. So this is very important to not have a very horizontal prosthesis. This is just 10 seconds. Thank you.
It's also here, like in this particular image, it illustrates sometimes difficulty in positioning decisions. Yeah, like you see that this bicuspid anatomy is such that on the non-side you seem to be much higher. On the left side, you're already very deep.
Yep.
So it's very difficult to aim for symmetricity here, you know, because it's a very special anatomic situation, the bicuspid anatomy with raphe. So this is, to my understanding, very elegantly placed valve, exactly as it should be. And we should all remember that bicuspid anatomy is much more risky, actually. It's been shown, as you correctly mentioned, with Notion trial, that the risk of complications and problems and in outcome with bicuspid valves
Higher than the
higher significantly than regular tricuspid valves. We can do it if the patient has high surgical risk. We know that, but problems are more likely.
Yep.
This is a very elegant case you showed.
Thank you. And we close the groin with single perclose and an angio-seal at the end of the procedure.
Very nice. I would propose that we move to a next case and then we can have a discussion afterwards. Is that okay? Because we are slightly behind schedule. There's not much time left. So let's move along with the second case, which is a valve-in-valve. And it's Dr. Javed, yeah? Let's do that and then we discuss during the remaining time, yeah?
Yeah, I would like to catch up with some time and keep it relatively brief. So I think it nicely sets up the scene that we have seen how to implant the valves in the normal cases or day-to-day cases, and bicuspid, and then one special anatomy with the valve-in-valve by conflict of interest. But what I'm just going to show a case of valve-in-valve TAVI, and then that outline that how the implantation technique may differ. And the reason I'm saying it differ is that the general principles, as Kenta said, are the same. However, all those things, whether through pre-dil or not, deployment depth, post-dil or not, all these things are part of, for me, they're part of the deployment or part of the implantation technique. So in that sense, there are differences which we will highlight. So a 72-year-old lady, she had an AVR in 2017 with perimount 21. She has this gastrointestinal tumor. She had previous stroke. She was admitted in hospital in one of our district hospital with worsening heart failure and peak gradient of 100 plus. Yes, as a routine, we discuss the MDT, but we know what's the answer, and patient is for TAVI. So I'm just going to quickly just go on to the TAVI planning. That this is a different situation now. It's a valve-in-valve one. We have got this nice valve-in-valve app that can give you some ideas what we are dealing with. So it's a 21 millimeter valve. You can see the valve height. You can see what's the true ID, what balloon you will need, what size valve you will need. On that ground, Hydra SMT is working to have the Hydra sizes on this valve-in-valve app to help with that. But yes, you can calculate based on the sizes. So this case was suitable for 22 millimeter Hydra valve, and obviously we were going to do pre-dil and post-dil. Important things in her case is obviously the valve-in-valve case. You need to be careful with the coronary protection. And this one, you're just saying that the height of the left main is about 10 millimeter and height of the leaflet is about 12.1 millimeter.
Can I stop you here for a second?
Yeah.
You have the blue circle of 24. Why is that?
not sure, we're not going to use it. It was just if we do because it was a fracturable or expandable valve, so it was just looking at whether if we expand it, can we go higher than that to avoid the ppm kind of thing. But yes, we found it
self-expanding valve will make it slightly smaller, which matches more or less the inner diameter.
The good thing on that ground was the VTC on both sides was reasonably good with the 0.53 and 0.51. We don't routinely do the coronary angiogram for all the TAVI patients, but in this one particularly, we wanted to see what the coronary ostia look like, and it's appreciating its depth in relation to the valve as well. And you will appreciate that the depth is, the height of the coronaries is relatively low. So the question was, what are we going to do? So luckily, we have got, I think, quite reasonable ideas from the published literature, which way you want to go. So the leaflets, of this case, extend above the coronary ostium. Answer is yes. The leaflet kind of just reaches to the STJ plane. Even if you use it yes or no, the VTC is more than 4 millimeter. So we thought we may be okay with conventional TAVI without basilica. I hope that's reasonable.
The only important thing here, in order to measure VTC, of course, you need a proper circle, which I was drawing your attention to. Yeah, like you would draw the circle the size you think your valve will be. So here, by choosing Hydra 22, probably a 20 millimeter circle would have been sufficient, and then indeed these VTCs would be anticipated.
Part of the reason for that one, that even if we fracture one, get the bigger one, even then it was 5 point something. So we were very safe with the VTC. That's okay. So keeping it brief, we just crossed the valve. Yes, bit of difficulty, and the gradient actually was quite high, as we knew from the echocardiogram as well, that it was 100 plus on echocardiogram. I think that was absolutely the right thing to do for this patient. We did predil, yes. I think that's pretty much, I will say, systematic routine thing. And I think this one is also interesting because we expanded, we put the balloon up and did an angiogram.
So I would just make a short comment here, but exactly, we rarely do predils in biological valve-in-valve procedures, but if we do exactly for this purpose. Then you use the opportunity to inject some contrast to answer yourself a question, are you going to have a coronary obstruction or not?
Absolutely. That's the reason, that's why I've just made this part when we have expanded the balloon and got it. And I think you can see the valve leaflet extending very close to the left main, also not obstructing the flow. Would anyone change the plan at that stage?
This is borderline, but you have flow. You could say you have flow.
Have flow, yeah. I think that was promising. But what it was, that it was enough to make it a little bit apprehensive. And then what we did was, I think, we said, okay, we need to have protection. I think that's the right thing in this case, that after the coronary obstruction, then we don't want to be in that situation. So we did the angiogram, we put the wire and the guide liner down at the left main as a protective.
Dr. Javed, what is the size of the balloon used?
That was 20.
Okay.
That is exactly why I suggested a circle of 20, exactly as your balloon. So well done.
So we have highlighted that point very well. I don't need to go into that. Hydra tracks very well. That's the bottom line. Even in this one was not particularly a Gothic kind of arch, but even those ones, we have seen it bends almost completely, and you can get it. But here also what you can see is that there's a lot of equipment there, and still I was expecting that it will be going to push my catheter in, out, or something. But no, it worked very well and tracked well. So, and then another thing which I'm not going into much details, but here we are thinking not necessarily the normal, even the depth of the deployment. So we did some modeling to see that what level we want to see. We wanted, because the coronaries are relatively down, we wanted it to be in the nicely expanded part of the stent and not in the inflow part of it. So we aimed for slightly deeper. And so that you have to tailor it based on your individual anatomy and for the reasons that you think that you want to do it. So I will keep it quick. We did exactly what you will say, that the angiogram, actually, to be honest, we'll learn from you to do it in those two views, and I think that has been working absolutely brilliant. And we hardly do the 3-cusp view for the self-expanding any valve. So we go to the 2-cusp view, and then we go to the isolated left, take the parallax off, and these two views give you all the information that you want. So and then as rightly at 80%, we wanted to see again that even at this stage, the coronaries are clear. The coronaries were okay, so we brought the guideliner back and did an aortogram. Still, it looks okay. Then we released the hydro valve. And as I said, that probably from the actual annulus, the depth is as recommended. From the actual valve, it's slightly deeper. But you can see that the curved part of the valve is where we want it to be across the ostium to give it a little bit more space at that. And we did the post-dilatation. Okay. And we were amazed to see this final gradient in valve with a 22 millimeter valve. Peak-to-peak gradient of 9. I don't have the data, but I'm quite certain that when this patient had the original surgical valve, immediate post-procedural hemodynamics would not have been like this. So I think that's the point for all the self-expanding valves, supraannular self-expanding valves, and the Hydra does very well for that. And again, we just wanted to make sure that the coronaries are okay, so we just kept the wire and did the aortogram and one with it. So we usually complete our all case with 2 aortograms. This one was a different one. So again, based on the special circumstances and not me, you will do what you want. And another point which people have highlighted is that how good Hydra is for coronary access. So now this is valve-in valve, the 2 valve, and see the right coronary and the left selective engagements. And we are happy that we get it. So I think the principles of valve deployment are same for self-expanding one. Just like principles of angioplasty are the same. You need to know the basic principles. However, the differences are there for the valve as well as for the anatomy. I think I will just finish it here, and so that we have got some time for the discussion.
Very nice case. Very nice.
So I just wanted to make that one. I was asked to make this one. So I just said one thing. Is implantation technique same for all? Principles are the same. Techniques, I don't think so. And it's not all for self-expanding. Even for the balloon expanding valves, I think you have to take in consideration and that even balloon expanding valve, one valve behaves differently than others. And to answer that question, I think one of industries have spent quite a lot of money and actually got that idea that the implantation techniques are not the same. And we know the accurate IDE trial data. And part of the data, we also know that they're coming up with these post hoc analyses to say that the implantation technique was not standard or was not optimal and resulted in suboptimal outcomes. So I think, yes, the principles are the same, but the implantation technique and depth is only part of the implantation technique, not the whole thing, is probably different for the self-expanding and the balloon expanding valves. But also you have to tailor these things, as you rightly said, when you are moving from for the same valve platform from the one iteration to other one, that might slightly be different. And definitely for the individual anatomy as well. We have seen the calcium, we have seen the bicuspid where valve-in valve. If there is pre-existing pacemaker, my threshold of going slightly deeper, for example, for some of them becomes easier decision. So I think many factors that make, and we have to individualize it based on the device and the patient that is in front of us.
Very well said. Giuseppe, you have a microphone. Go ahead.
Yeah, I just want to, make, let's say, final thoughts related to the general concept to take away. So the general concept is that on top of pre-procedural planning, on top of the peri-procedural planning, what is important is to optimize what you have done. So that means that you need to measure the invasive gradients, but intentionally you need to orient the valve. For instance, the case that he showed before is important because when you go for coronary protection, it's extremely mandatory that you orientate the valve in a proper position to avoid to go with the skirt in front of the coronary, because in that case you can nullify any rescue basilic or things like that. So valve optimization matter a lot.
Ignacio.
Just one quick comment. I think that one of the key
Yes.
points of this valve is how easy is the reposition. So I totally agree with you that finally we need to be totally sure that the position is good, because you can reposition the valve. You have seen how easy it is to reposition the valve, and also how easy it is to have the markers in a nice position. So you are totally sure when you deploy that you are going to have a good result. So I think that is a key point, especially in this type of cases that you have already shown. For valve in valve, or in a case like you did with the bicuspid, we need to be sure that we are in a nice position, because this is going to change probably the prognosis of the patient. I mean, commercial alignment and this type of cases show that finally the gradient that you get probably is going to translate into clinical outcomes. So I think it's quite important to have nice position, nice deployment, post-dilatation in case that you need it, because especially for young patients, I'm now considering this type of valves as fair option, because you can have a second valve inside in the future. Probably the overhanging of the leaflets are not going to be difficult for the second deployment. And also the gradient that you are going to get is going to be much, much better than for balloon expandable.
Yeah.
So
An interesting observation, Gintas. I'm going to put you on the spot. How easy is to commercially align the Hydra compared to the competition?
That's a very good question. And I haven't fully cracked it yet. As far as I know, we had this discussion with the company actually. Can you rotate the valve
Yes.
after it's crossed the valve? And it appears you can. I recently received a video showing that on the bench. I have not yet tried it myself in a patient, but on the bench it does rotate and it does translate. So this is to be investigated. Fair question.
Yeah, that's important.
Yeah.
The second thing I wanted to talk about his case. He had a gradient of 9 on this. I'm sure it'll be much higher the next day. Would you routinely fracture a small valve or not?
Not routinely. Yeah, I would say safety first.
Yeah.
I
But
consider
what would you
fracturing-
find unsafe in doing this?
Well, primarily coronary ostia, that's one question.
In this one, yes.
In this one,
Otherwise,
yes,
yeah.
unsafe for sure.
Sure.
To my understanding, I
So-
would not do that.
We had another case where the balloon needed for the fracture was just slightly bigger than the calcified STJ. So we elected not to fracture. So I think safety first.
So that's the important case in point that we have to say, that you need not go and fracture every valve. because that-
Especially when you have a low gradient anyway.
Yes.
Why would you risk it?
And if you have these bad anatomies, you would end up causing more problems than benefit.
I think also it appears we have run out of time, I think. So, Javad, why don't you, I think we need to close the session unless there is any one burning comment from the panel.
I think I will probably just give 30 minutes to Dr. Anmol as well. He has been. And any comments on this one? And then with 30 seconds, not 30 minutes.
I was a bit worried already.
Yeah.
No,
Go ahead, Anmol.
with the sizable experience with this platform, I think this is one of the bovine pericardium, the only platform which is bovine pericardium supraannular, which is available as of today in the market. Second thing, the utility of this valve with that marker makes the life of an interventional cardiologist much easier. And I think I don't have to emphasize anything. The Gintas and you have already explained the deployment techniques very meticulously. I just have one last question for Gintas. As he has emphasized on keeping the valve centrally located, do you have any tips and tricks depending on the wire, whether you can use a little less stiffer wire to make the system centralized? Because majority of the times what we see and what we have practiced and felt, the usually device tend to go on the outer curve or inner curve. So any tips for that, for a wire point of view?
So I would think we primarily tend to choose stiffer wire, such as Lundquist wire, when we have either issues of crossing tortuous femoral anatomy, borderline small tortuous, it helps a lot, or we have problems crossing or difficulty crossing very steep aortic arch, or we have problems crossing unfavorable aortic routes, such as valve in valve or bicuspid or some unfavorable chunky leaflets, then stiffer wire helps to straighten the trajectory and to avoid unfavorable kinks there. When it comes to centrality, I think it's more, to my understanding, less so the stiffness of the wire rather than the tension on the wire. So you can, with both stiffer wire and softer wire, you can either increase the tension on the wire by pushing forward into the ventricle or decrease that stiffness by pulling back. So I don't think we change the wire to centralize the valve so much. It's more other reasons that I just outlined.
Okay, that's excellent. Thank you very much. I think this discussion can go on till post-dinner, but I think we should close it. And thank you very much, SMT, to your PCR London Valve, and to all the faculty here for the excellent discussion. And thank you very much for all of you to come here. I think the points that we wanted to cover have been covered very well. So I would like to thank you all and close the session.
Thank you so much. Thank you.